Then we have what we call Hirschsprungs. So by the Hirschsprung, the spelling I've given you there is a bit wrong. The right spelling is HIRSCHSPRUNG. So there is a CH there after the S. Between the S's, there is CH. And there's an S there after. So it's HIRSCHSPRUNG. Hirschsprung's disease. Yeah, so that's called Hirschsprung's disease. So let's look at the congenital anomaly of the large intestine. And the incidence is around 1 in 5,000 live births. So we have 5,000 children who are born, you are likely to have one who have Hirschsprung disease. And it is more common in males. Yeah. And mostly the reason it occurs is because due to incomplete migration of neurocrest cells. Remember when you talk embryology, go back and look at it. There's what we call neurocrest cells into the hindgut, resulting in distal aganglionosis and failure of coordinated peristaltic waves. So there will be abnormal failure of coordinated peristaltic waves. There will be abnormal anorectal relaxation, and there will be loss of rectoanal inhibitory reflexes. So it's due to incomplete migration. Remember, neurocrest cells usually migrate from the cephalic region, that is towards the head region, towards the caudal region, that is towards the tail. And sometimes as they migrate within the intestine, they don't go all the way to the rectum. So there is due to incomplete migration of neurocrest cells into the hindgut. Remember, there was the foregut, midgut, and hindgut. So go look at them again and review. So there are no ganglion cells there. Basically, the nerves that are within the enteric nerves are not there in that distal end, that is towards the end. And so the normal peristalsis of the intestine that is supposed to move things distally, the anorectal relax, those sphincters do not relax normally, and those inhibitory reflexes are lost. So you can imagine this is likely to occur early in life. So the child may be born, and within a few days, they're not passing meconium. Usually a child, when they're born, they're supposed to pass, I think within 24 hours, what we call meconium. Meconium is like the first stool. Usually it looks dark and gel-like stool. We call it meconium. I'm sure you'll be able to look at it when you come to the clinical area. So that child is likely not to pass stool. And then later in life, they're likely to have things like constipation, enterocolitis, that is inflammation of the intestine. They're likely to have a recurrent abdominal pain and so on, because they are not passing, the entire large intestine doesn't have nerves. Basically, it's not innervated. Yeah, and then if you go to the next, there is a diagram just showing the same. So you can see the ganglia is coming up to some point. Those star-like ones are the ganglia. And then you see at the end, there is no ganglia there. Yeah, so there's a ganglionic end towards the end. We have ganglia here. So this is the normal part. So mostly what will happen, so the proximal part will be dilated because it will be full of stool. So the other part is not contracting. So the stool is not going to go past that. So this proximal part will be dilated. In pediatrics, you are likely to find a patient with Hirschsprung's disease. And then we have what we call microscopic colitis, lymphocytic, and collagenous colitis. Colitis basically will be referring to inflammation of the colon. So somebody is likely to present with watery and bloody diarrhea with normal colonoscopy. So when you do colonoscopy, you find it normal. But there is subtle inflammation of the lamina propria with increased lymphocytes and apoptotic bodies in the epithelium, also in the subepithelial collagen band in collagenous subtype. It is thought that it has a connection with autoimmune disease. So it's thought that it could be caused by those autoimmune diseases, basically forming antibodies against self. Then there is what we call ulcerative colitis. Yeah, and this one is likely to present with bloody diarrhea, pain, fever, toxic megacolon. So when you talk of toxic megacolon, basically the colon is markedly enlarged. So then there is likely to be inflammation and ulceration of mucosa. There's likely to be crypt abscesses, that is where glands were, there will be some small abscesses there. The crypts are also distorted in architecture. And then there is what we call inflammatory pseudopolyps. So it appears like polyps are basically growths within the intestine, the lumen of the intestine. The one we call pseudopolyps. So they look like polyps, but they are not. And then it's usually chronic relapsing inflammatory disease of the unknown cause affecting the large bowel. So mostly this one, the cause is really not known. So it's more of idiopathic and mostly affect the large bowel. That is the colon. That's why it's called ulcerative colitis. And this disease always involves the rectum, but often extend proximally to involve the whole colon. So mostly it will involve the rectum, but it can go on to involve the descending colon. It can involve the transfer. It can go all the way even to the entire colon. And sometimes it is accompanied by systemic features such as anemia. Yeah, because sometimes you have bleeding, bloody diarrhea, for example. So if you lose blood, you're likely to develop anemia. You are likely also to have arthritis, that is inflammation of the joints. Then uveitis, that is inflammation of the uvea, that is within the eye. So if you look at this particular condition, if you do colonoscopy, you see some ulcers, and these ulcers will usually be superficial rather than fissured as in Crohn's disease. So unlike Crohn's disease, the ulcers will be superficial and not deep. So usually the changes are mainly confined to the mucosa. So in ulcerative colitis, those changes, those lesions will mostly be confined to the mucosa and submucosa. So it doesn't really goes beyond that. So there will be repeated episodes of inflammation, ulceration, epithelial degeneration. They lead to dysplastic change in constantly irritated epithelium. So if it's not treated well, then those inflammation may be repeated. And so you end up with dysplasia. And this usually contributes to high incidence of colonic adenocarcinoma arising in patients with a long history of ulcerative colitis. So people who have had a long history of ulcerative colitis for many years, they are at risk of developing adenocarcinoma of the colon. Usually tend to be more common in the second or third decades of life. Yeah, and mostly tend to affect females more than males. Of course, it affects both, but tends to be, from the researchers, tends to affect more females than males. Of course, as I've said, there's what we call pseudopolyps tend to be common, basically because of inflammation. So some parts are inflamed, some others are, and parts are not inflamed, so you end up with what we call pseudopolyps. Of course, there is a diagram there showing ulcerative colitis. As you can see, mostly, as we said, it always affects the rectum. Yeah, and then you can see the pseudopolyps. Those dotted, those would be the pseudopolyps. And then you remember the large intestine, there's what we call hostra. And so for somebody who have had a chronic ulcerative colitis, if you look at their large intestine, their intestine looks like what somebody will call lead pipe. It looks like a pipe that is smooth. Yeah, because there is loss of hostra. And then the large intestine will tend to become shortened in severe cases. And of course, there will be some superficial ulcers, as we have said. That is a histology, a diagram of a histology, what you are likely to see in ulcerative colitis. Crypt abscesses, you will see inflammatory infiltrate, the mucodepletion, basically the cells that produce mucus will be depleted, then will be superficial ulceration, the blood vessels or the capillaries within it will tend to be congested. Then there is what we call diverticular disease, diverticulosis. This is basically somebody may present, so somebody with diverticular disease affects the large intestine. Somebody may present with altered bowel habit. Basically, to mean if somebody has been having a normal bowel movement, they're likely to start having diarrhea. Sometimes they are constipated. That's what we mean by altered bowel habit. So it's changed. It's not more than the normal that we expect. And then they're likely to have pain on the left iliac fossa. That is where, of course, you'll have the sigmoid colon, the descending colon, and so on. Because that is where they are most common. And then they're likely to have rectal bleeding because this diverticular, basically diverticular is outpoaching from the lumen of the wall of the large intestine. So those outpoaching are likely to become inflamed. They're likely to develop diverticulitis, and they're likely to bleed. And so somebody can come with rectal bleeding. But most of the time they're symptomatic. Most of the time we discover them during colonoscopy, that you discover somebody of diverticular. So basically, it's herniation of mucosa through the vascularis propria with surrounding inflammation and fibrosis. So there could be surrounding inflammation and fibrosis. And mostly it tends to be more common in the elderly. So it may involve any part of the colon, although the sigmoid colon is the most frequently and severely affected. That is why you will feel pain on the left iliac fossa, because that is the rough location where the sigmoid colon is. So it is thought that it's probably arising from a high intraluminal pressure associated with low residue diet and subsequent constipation. So low residue diet, especially in developed countries or people who live in town, low residue diet, high residue diet will be like high fiber diet, like the ugali that twisiaga, pakisiagi, fruits, vegetables, but things like rice, those things that are very low fiber, those are the ones that are likely to lead to constipation. And so if constipation continues over a long time, you are likely to develop high pressure within the lumen, and you are likely to develop diverticulosis or diverticular disease. So when you look at it under the microscope, there is marked hypertrophy of the circular layer of the muscle layer. Remember, the intestine, basically just the entire GIT, you have the inner circular layer and outer longitudinal layer. So if you are to look at this, you feel like there's hypertrophy of the inner circular layer of the muscle layer. So you can develop inflammation, that is diverticulitis, may develop following obstruction, that is obstruction. So there is a B there, obstruction of the narrow neck, that is a neck again, there is a typo there, neck of a diverticulum. So if that neck of the diverticulum is blocked, then there is likelihood of there being inflammation within that diverticulum. So that's what we call diverticulitis inflammation. And these are some of the complications that if you don't deal with it, it's likely to complicate, likely to bleed. Yeah, it's likely to erode into blood vessels and bleed. It's likely to perforate. And if it perforates, it may lead to spilling of intestinal content into the peritoneum, and you have with peritonitis. You can have paracolic abscess formation, so abscess around the colon. You can have fistula formation with other viscera. That is viscera. There is a C there. V-I-S-C-E-R-A. So other viscera. So they're likely to, such as urinary bladder, is likely to develop a fistula, a connection. A fistula is basically an abnormal connection between two epithelial surfaces. So you can have connection between the large intestine and the urinary bladder. You can have a connection between the large intestine and the vagina. So you can imagine if there is connection between the large intestine and the urinary bladder, you're likely to have, when you pee or passing urine, there's likely to be fecal matter within the urine. And maybe in this case, it's connecting with the vagina, you're likely to have stool coming out of the vagina, for example. So that will be a fistula formation. So those are some of the complications that can occur with diverticular disease if it is not well controlled. There's a diagram there showing diverticular disease. You can see those outpoaching. Yeah, that's the large intestine with that tibia. It's affecting all the layers, for example. You can see it there. Then we have polyps. And these are usually what will lead, if these polyps are not well controlled, which will be mostly in the large intestine, it can lead to colon cancer. So you can have a polyp we call hyperplastic. So you can see from the name, or you can hyperplastic or metaplastic. So usually most of these polyps will be this incidental finding, or somebody can come with bleeding. And so when they do colonoscopy, they find that they are polyps. So polypoid glandular lesion with sawtooth architecture, but no dysplasia. So you look at them, there's no dysplasia under the microscope. So mostly very common in large bowel, especially the rectum sigmoid. That is the junction between the rectum and sigmoid colon. And most of the time, these hyperplastic polyps, they are small, but they're often multiple. That is more than one, there are many. Most do not themselves have malignant potential. So when you see this, they rarely have malignant. That is, they rarely change and become cancerous. However, there are exceptions where you have, for example, a rare hereditary hyperplastic polyposis. So that can lead to cancer syndrome. When you have that syndrome, so however, have a malignant potential, and they tend to develop invasive adenocarcinoma. So initially is more common in the elderly, especially in the people within their 6th to 7th decade. And they are composed of long and cystically dilated glands and crypts lined by normal epithelial cells. Then we have what we call serrated adenoma, which is also an incidental finding. So it tends to be found because somebody come with rectal bleeding, and when you do colonoscopy, you find there is that adenoma. And also it has a polypoid glandular lesion with sawtooth architecture and variable dysplasia. So this is associated with a significant risk of developing adenocarcinoma. So when you find this serrated adenoma within the colon, then there is a higher risk of developing adenocarcinoma. So most of the time you need to remove them. During colonoscopy, you are supposed to excise it completely because there is high risk of developing into cancer. Then we have what we call tubular adenoma. Also, most of these is also an incidental finding. That is means somebody just came with bleeding, rectal bleeding, and so on examination, on doing colonoscopy, you find there is this adenoma. Usually also will present as a polyp, usually with a stalk and glandular architecture with variable dysplasia. It's the most common type. This adenoma is the most common type. Around 75% of them will be tubular adenoma. And it's more common in males than females. So that they could either be solitary or multiple. So this tubular adenoma could be solitary or could be multiple. That is many. And we have a condition we call familial adenomatous polyposis. That is, in this case, if somebody will have numerous tubular adenomas developed throughout the colon with a high rate of progression to adenocarcinoma. So you do colonoscopy and you realize there is a lot of these polyps all over the place. There are so many. That is what we call familial adenomatous polyposis. So usually they have a very high rate of developing to adenocarcinoma. So they're likely to develop colon cancer. And the malignant potential for this tubular adenoma is around 5%. But of course, when you have the familial adenoma polyposis, the high risk is higher. Then we have what we call villus adenoma. It's also an incidental finding. That means somebody comes most of the time with rectal bleeding or discomfort in the abdomen. Then when you do colonoscopy, you find the villus adenoma. So it's usually also a polyp, usually sessile, villus architecture with variable dysplasia. On top of sessile, it doesn't have a stalk. That is, it is just slightly raised and lying on the surface of the mucosa, for example. So it will appear, it doesn't have a stalk. So that's what we mean by sessile. And this one is much rarer. The mid-age is around the 6th decade. That is where most of the people will present with this villus adenoma. So usually arise from, when you talk of sessile, it means arising from a broad base, so it doesn't have a stalk. So it's composed of narrow frond-like outgrowths of epithelial cells supported by a delicate connective tissue stroma, giving a papillary appearance both histologically and with the naked eye. So when you look at the naked eye, that is how it will look like. So fronds, I'm sure some of us have seen some fan. You've seen a tree called a fan. Probably some of you have seen it. So it looks like that appearance. So the clinical potential in this case is quite higher. It's about 30%. So most polyps usually with these adenomas and so on, any polyps usually, when you do colonoscopy and you find polyp, you should be able to resect all of them ideally. Yeah, you're supposed to resect all of them because all of them have some potential to progress to colon cancer. So sometimes there is excess secretion of mucus, can be seen. So somebody may present with a lot of mucoid stool, and so they are likely to have villus adenoma. So, so most of the time, villus adenoma tend to be symptomatic. That is, most of the time it tends to have either somebody have abdominal pain or they tend to come with bleeding per rectum. And so when you examine, you find them. So when they are there, there will be some symptoms also, either somebody having rectal bleeding or abdominal discomfort. Then we have tubulovillus adenoma. You can see, as you can see from the word tubulo and villus, so combination. So also it's an incidental finding because somebody comes with something else like bleeding, abdominal discomfort. Then we examine and we assess the patient. Then you find this, and it will appear, if you look at it, maybe under the colonoscopy, you see a lesion that is polyp, like a polyp. And in do histology, you see glandular and villus architecture with variable dysplasia. That is under the microscope. And it has around 25 to 50% villus architecture. Remember, it's tubular and villus. So it has, the other percentage will be tubular. And of course, there are diagrams there that you can look at them, the different types. Yeah, that I've just shown there. I'll you to go look at them on yourself to try and do read more, of course, about those polyps. Unfortunately, because of the time that we have, we are not able to go into a lot of detail. But I really encourage you to read more around what we've discussed. So this is basically where I'll set the exams, and this is what I think is important. Of course, there are many other things that we probably don't touch, but this is what I think is important for now, and it will help that you read around those in some detail and people submit around it. Yes. So of course you can see this. There's what you call adenocarcinoma sequence. That is why most adenomas, if you find in the colon, you're supposed to remove it. You're supposed to excise it completely because there is that risk of it progressing. So you can initially have a mucosa that is at risk, and then you have a hyperplasia that is increasing cell size, cell number of the mucosal cells. Then you end up developing adenoma with dysplasia. Then you end up with carcinoma in situ. I'm sure we talked about carcinoma in situ in pathology 1. So be able to go back and revise it again. So if you don't do something about it, you end up with invasive carcinoma. That is why if you find it at the stage of polyps, you should be able to resect it in total so that you don't allow this progression to continue. Then we have finally the adenocarcinoma of the colon. So all these polyps and so on, they increase the risk of this. And that is why you need to deal with them. Once you find them, most of the time after colonoscopy, you should be able to try and remove them surgically. Yeah, mostly you can actually do it through a colonoscope. And this one are likely, somebody is likely to come with hemorrhage. So they're likely to come having rectal bleeding. Of course, they're likely to come with abdominal pain. They're likely just to come with anemia. Anemia is low hemoglobin level, especially if it is the adenocarcinoma affecting the right colon, that is the cecum, maybe the ascending colon, because they have a bigger lumen. So it's unlikely to obstruct it early. So that body is likely to be bleedings, very small bleeding and so on, and they end up with anemia. Of course, if it is enlarged and is growing into the lumen, it's likely to completely cause the blockage of the lumen. And so you have obstruction, you have intestinal obstruction. Yeah, of course, it can grow around the lumen and narrows it. And finally, you end up with obstruction. Or it can grow into the lumen, causing the obstruction. So looking at the microscope after preparation, of course, you're likely to see invasive glands with a typical epithelial cells. And there's usually some mucus production. There's what they call dirty necrosis in the lumina. So within the lumen, you'll see a necrosis that looks dirty, so to speak. And mostly tends to affect rectum. In 60% of the time, it tends to be in the rectum. So that's why you will see something anorectal carcinoma. You mostly most of the time talk of colorectal. So most of the time, 60% of the time is likely to affect the rectum. It's a very common malignant tumor of the colon. Around 98% of the cancer of the colon will be the adenocarcinoma. And most of the time, it tends to affect the sigmoid colon and rectum. As we said, in the rectum, around 60% of the time. So macroscopic pattern growth, that is if you are to look grossly under the naked eye, they're likely, tumors may consist of a central ulcer with raised margins, so there is an ulcer in the middle, then the edges are raised. Some tumors may infiltrate the entire circumference of the bowel wall, so some tumors may infiltrate it around, forming an annular stricture. They may develop a protuberance, that is something protruding into the intestinal lumen, cauliflower-like, that is exophytic. Exophytic means growing out. So in this case, into the abdomen or even out into the peritoneum cavity. So they may have a mass here, especially in the cecum and proximal colon. So proximal colon, we are talking about the cecum and ascending colon. Because I say those two, usually their lumen is a bit wider if you compare it with sigmoid colon. The right side of the colon the lumen tend to be narrower. So most of the time they will present with obstruction quite early because they are narrow. But the right side of the colon, the lumen tend to be larger, and though that's why it gives it the ability to grow inside the lumen as exophytic cauliflower-like mass. And of course, adenocarcinoma of the colon, very common disease, and of course has been studied a lot. And there is a way you stage, so that there is a stage we call Duke and others. Of course, there are so many others. So this is the one that I thought maybe you should have had an idea. There is so much you can learn about colon cancer or adenocarcinoma. So there is a classification, the staging that's including this one, Duke. So Duke A is basically, if you look at under the microscope, the tumor is confined to the bowel wall, that is just within the bowel wall. But if you do Duke B, is extended to the pericolic fat, that is the fat that is around the colon. And then Duke C is presence of metastasis in the lymph node. So if you look at the lymph node around the colon, there will be, that tumor has gone there. So that will be Duke C. And of course, this one is important because it helps you in management. Most appear moderately differentiated with a clearly defined glandular pattern. So most of them will be moderately differentiated. And the incidence tend to rise with age, average around 60 years. So as people age, so it's a more common disease in the older generation. But of course, nowadays it has become common in all age groups, apparently, for some reason that we don't yet know. But initially, at least, it used to be more common in the elderly. So it can spread directly, that is from the colon to the just nearby structures. In this case, it can go to the lymph nodes and then the nearest structure. So that is direct spread, direct extension. It can go into the lymphatic system. It can go into the blood. And this one, hematogenous, tend to be late. So it tends to come later. So usually when you have one that has spread, it means it has been there for much longer. So of course, when it goes to the blood, it mostly will affect the liver. It can go to the lungs. It can go to the brain. That is brain, not rain. There's a lot of type of brain. It can go to the brain. It can go to the bones. It can go to the ovary. It can go literally to any organ within the body. Yeah, so that is brain. And of course, there are a lot of investigations that you can do, including CT scan of the abdomen, MRI of the abdomen. You can do colonoscopy, and during colonoscopy, you can be able to get a biopsy for histopathology to be able to confirm it. Remember, for cancers, you always have to do tissue diagnosis. You have to have a tissue diagnosis. Yeah, a cancer of any sort, you cannot say this is a cancer before you have a biopsy and have a tissue diagnosis. They usually say cancer. For cancers or carcinomas, tissue is the issue. You have to have a tissue diagnosis. You have to have a tissue diagnosis for you to confirm that is actually a cancer. And of course, you can see from that diagram there, that is how it can appear. You can see mainly on the right side of the colon, that is the sigmoid ascending colon, it will tend to be exophytic, that is forming cauliflower-like, a tumor growing into the, because the caliber of the lumen tend to be wider there. And when you look at the left side of the colon, it tends to be a napkin ring configuration. That means it grows within the wall of the cell, causing it to constrict like a napkin configuration. So right-sided growth generally tend to be cauliflower. You can see that one in that picture. So the lower ones are real pictures. You can see growing into the lumen like a cauliflower. So you go check and look at the cauliflower, fungating, call it fungating. But when you look at the right side, it is just constricting. So it's growing into the wall, causing it to narrow. So napkin ring configuration. Then there is what we call GIST, gastrointestinal stromal tumor. And this one can present with bleeding, either of you have vomiting blood or bleeding per rectum. You can have a mass within either of the tissues, the stomach, or even the small or large intestine. You can have a mass. Most of the time, it can also be an incidental finding. And most of the time, it is the stomach or the small intestine. So this one mostly affects the stomach or the small intestine. And if you are to look under the microscope, that is, you take a tissue, then prepare it, and prepare it and look under the microscope, the cells that you're likely to see would be mainly spindle cells in collagenous stroma, less commonly epithelioid or pleomorphic. So it's a specific type of mesenchymal tumor. So it originates from the mesenchyme. I'm sure you need to go back again at the embryology, look at what is mesenchyme and so on, so that you can be able to understand this better. And it is thought to be derived from interstitial cells of Kajal or a precursor cell. So go check what we mean by the cells of Kajal. And they have a wide spectrum of clinical behavior. That means basically they can present in very many ways. There is no specific way that these tumors can present. Somebody can come with bleeding, a mass lesion. Sometimes they may just have abdominal pain, and when you examine, you find this tumor. So about a quarter of the gastric GIST and a half of small intestine GIST are frankly malignant. So a quarter of the GIST. So some GIST are not malignant, but a quarter of them is in the stomach, that is gastric, will be. A quarter of them will be malignant. And then in the small intestine, half of them will be malignant. The most useful pathological feature that predict malignant behavior are sites, so where it is located, size of the tumor, and high mitotic rate. So if you have, and look under the microscope, you see they have a very high mitotic rate, then that is likely to become malignant, or it's malignant. If the tumor is larger, it's likely to be malignant. The location, yeah, so in this case, for example, if it is located in the small intestine, then there is a higher chance that it could be malignant as compared to if it is located in the stomach or gastric. So usually the treatment here, there is no like medication that you can give. Most of the treatment will be you need to excise it. That means you need to cut it out completely. So complete excision usually will be the treatment. So our hope usually is that it is discovered early so that you can completely excise it. So the main treatment will be surgical. Then carcinoid tumor. Most of the time it's incidental finding. Incidental basically means you are looking for something else, or some patient was presenting with what you thought could be something else only to find this. And mostly, as I've already mentioned, I alluded to earlier, it's common in the appendix or small. So of course, it's an incidental finding commonly in the appendix. So when you do appendicectomy, you look at it, and you do histology, you find there is a carcinoma tumor. Or it can come, somebody can present with small bowel obstruction. That means the small bowel or the small intestine is obstructed. And they're likely to present with carcinoid syndrome. When you talk about syndrome, basically you're talking of a number of symptoms that will come representing a certain condition. So it's not one symptom. So we talk of carcinoid because these tumors can produce hormones in themselves. And so they can cause symptoms that are not very specific for a condition. So looking under the microscope, that is microscopically, you are likely to see small uniform cells with round nuclei, stippled chromatin, and pinkish granular cytoplasm. That is under the microscope. So most of the time, these carcinoid tumors will be found in the appendix, small intestine, rectum, stomach, and colon in that order of frequency. So more frequent in the appendix, followed by the small intestine, followed by the rectum, followed by the stomach and colon. Yeah, but it can also be found in other sites, like the pancreas or even the lung. So their behavior, these carcinoid tumors are not necessarily always malignant. Some of them may be benign, and some can be malignant. And this may secrete hormones, as I've already said, such as serotonin, which may cause carcinoid syndrome. So usually the hormones that cause those syndrome, as I said, syndrome will be a group of symptoms or signs that will point to a certain condition. So carcinoid syndrome. Then Crohn's disease, as I said already, alluded to when I was talking about ulcerative colitis, that usually this one tends to be differentiated from Crohn's disease. Both of them, ulcerative colitis and Crohn's disease, are called inflammatory bowel disease. Inflammatory bowel disease causes inflammation of the bowel. Most of the time, for ulcerative colitis is mainly the colon, but Crohn's disease can affect all the way from the stomach all the way to the colon. Yeah, so that is one will be one of the differences between Crohn's disease and ulcerative colitis. So in Crohn's disease, somebody is likely to present with diarrhea, weight loss, obstruction. They're likely to come with fistula formation, usually small bowel, colon, but can affect mouth to anus. So most of the time it's found in the small bowel and large bowel, that is the colon, but can affect all the way right from the mouth to the anus. So it can affect the entire GI system, unlike ulcerative colitis, which is mostly the colon, the large intestine. And unlike ulcerative colitis, you have transmural inflammation. That means mainly when you look at the ulcerative colitis, the inflammation is tend to be confined to the mucosa, but in this case it's transmural. When we talk of mural, that is affecting the entire wall of the gut. Yeah, so it's transmural inflammation. They're likely to have granulomas forming, fibrosis, fissuring, ulceration. That means the ulcers are going all the way. And that is why fistulas are more common here than in the ulcerative colitis. And then we have what we call skip lesion. That means a lesion developed, then there is a part of the mucosa that is normal, then you have another lesion there. Unlike ulcerative colitis, which tends to affect uniformly the entire mucosa. So skip lesions. So there's usually, if you were to look under the microscope at the wall that is affected by Crohn's disease, you're likely to have chronic inflammatory disease of unknown etiology. So this is a chronic inflammatory, that's Crohn's disease, just like ulcerative colitis, a chronic inflammatory disease of unknown etiology or cause, which may involve the small intestine, especially the terminal ileum. So it tends to affect the terminal ileum. Remember, in the small intestine, we have the duodenum, then you have the jejunum, and then you have the ileum. So terminal ileum is just before it joins the large intestine at the ileocecal junction, before it joins the cecum. So that is what we call terminal ileum. So it's more common around there. So if we are characteristically there's characteristically party distribution, affecting short segment with lengths of normal bowel in between. That's what basically we mean by skip lesion. So it affects here, then there is a gap that is normal, then there is a lesion again. That's what we talk about skip lesion. And that differentiated from ulcerative colitis, which tend to affect uniformly the entire mucosa of the colon without those skip lesions. And so there will be marked edema and inflammation of some mucosa, producing typical cobblestone macroscopic appearance of the mucosa. So if you look at the mucosa, it looks like cobblestone. And you can go and check what a cobblestone look like. So if you look at the mucosa, that is how it looks, in which domed areas of swollen mucosa and some mucosa are crisscrossed by linear depression caused by narrow fissure ulcers. So you have got cobblestone appearance. So fissured ulcer may extend into and even through the submuscularis propria, giving rise to fistula. So it can extend through the entire wall and end up becoming a fistula. So you end up having an abnormal connection between nearby nearby organs. So non-caseating granulomas can also be seen, and infiltrate of mononuclear lymphocytes. Cells like lymphocytes, plasma cells, and macrophages are likely also to be seen. That is looking under the microscope. You take a tissue and prepare it, you look at it, you see that caseating granulomas, you see lymphocytes, plasma cells, macrophages in that tissue. And then you're likely to see patchy ulceration, as I had said, because there are those skip lesions. So if you look at Crohn's disease, usually the malignancy, if it is not well controlled, they're likely to develop lymphoma. Yeah, so lymphoma more than carcinoma. So they tend to develop lymphoma. Remember, in ulcerative colitis, adenocarcinoma tend to be more common. Yeah, but in this case, in Crohn's disease, lymphomas will usually tend to be more common. So there's fibrous, there's stricturing. So in this case, unlike ulcerative colitis, there's likelihood to be narrowing of the lumen because of strictures. For fibrous, because of their skip lesions, so it's likely to narrow the lumen. So basically a picture there, or a diagram showing a Crohn's disease. As you can see, mostly it affects the terminal, more common in the terminal ileum. You see terminal ileum at the left, that is the cecum at the very left there. And you can see the ileocecal junction, that is the junction between the ileum and the cecum. And you can see the involved segment. Yeah, you can see some ulcers there. You can see the cobblestone-like mucosa. And then there, and if there's an involved area there, then after that, you probably will see another area that is involved. So that's what we call a skip lesion, which is characteristic of Crohn's disease. That is just a histology, the diagram of it, and then the microgram there. You can see what we are saying, deep fissures. That's why fistulas would be common. Swelling, that is edema with the mucosa. And caseating granulomas. Then the mononuclear cells, the filtration, and it's transmural. That is affect all the layers of the wall, from all the way from the mucosa and mucosa all the way to basal layer and serosa. And that will be what a micrograph will look like. which has been prepared using the methoxylin eosin, and that is the magnification times 200. So we are really grateful. It's a long one. Generally, pathology 2 is almost like anatomy 2. There is so much. And this is not all. This is what I basically picked and thought that probably these are important for you guys to know. So just